Thank you very much for the kind introduction. I'm very pleased to be part of your Congress and very happy to have been invited. I'd especially like to thank the Congress President, Dr. Al-Madani, as well as the head of the organizing committee, Dr. Al-Rukin, and also thank the moderators of this section, including our former resident, Dr. Al-Kilani, who was very kind in inviting me to present the topic of sudden unexpected death in epilepsy, or SUDEP, today. I'm very happy to talk about this topic because as we'll develop, it's a very important thing to recognize in neurology practice. So when I was training in the early 1990s, SUDEP really wasn't very well recognized or discussed, even though it was known for centuries that patients with epilepsy could experience sudden death. And it's really only been in the last 15 years or so that the number of publications, as measured here in PubMed, has tremendously exploded, reaching a number of over 200 in the last year, and I think this current year will far exceed this number. SUDEP can be defined as a sudden unexpected death in an epilepsy patient that's either witnessed or unwitnessed, with or without a seizure, but not due to some other cause of sudden death, such as trauma, drowning, suicide, or status epilepticus. And if the patient undergoes an autopsy and the autopsy does not reveal another primary cause of death, we then call that definite SUDEP. We call it probable SUDEP if the patient meets all the conditions above but does not have an autopsy, and we call it possible SUDEP if another competing cause of death is present, such as ischemic cardiac disease or a hemorrhage or stroke or something like that. And then there's another category that we call SUDEP plus, which is all the conditions of SUDEP plus another contributory illness such as cardiomyopathy or pulmonary disease or something like that. And then we've also got this category of near SUDEP in which a patient experiences a sudden cardiac or respiratory collapse but is resuscitated and survives for at least an hour. Most often this happens on epilepsy monitoring units. It's theoretically possible it could happen at the patient's home as well. So SUDEP poses the leading cause of premature death in epilepsy patients. And patients with epilepsy face a risk of sudden death that's 20 times higher than the general population. But it's also probably very much underreported because there isn't a single specific pathognomonic finding on autopsy. And a lot of medical examiners still to this day don't really recognize SUDEP as a primary cause of death. So when I show you these numbers about rates, remember that these are probably underrepresented. So on the left side in the figure, this comes from a study by Davensky and colleagues published in 2016 that shows that the severity of a person's epilepsy probably matters quite a bit. For example, in studies that look at a population-based cohort of people with epilepsy, which includes, of course, people with well-controlled seizures and relatively benign conditions of epilepsy, the rate of SUDEP is only about 1 per 1,000 per year. 1 out of every 1,000 patients will die per year. But in patients that come to an epilepsy clinic and presumably have a little bit more difficult seizure control, a little bit more tricky form of epilepsy, the rate climbs to 2 per 1,000 per year. In patients with intellectual disability or who reside in residential care facilities, the rate climbs to 3.5 per 1,000 per year. In patients with refractory epilepsy, over 4 per 1,000 per year. And in patients who are referred to epilepsy centers for epilepsy surgery or vagus nerve stimulator therapy, a rate of over 6 per 1,000 per year. And remember, these are probably underrepresented. In the bottom part of the figure from the same paper, this shows the distribution of SUDEP and highlights the fact that this is a condition of young people. The peak incidence is in the 30s, followed by the 20s and the 40s. And SUDEP is relatively infrequent in older adults and very young children. As such, SUDEP poses a significant public health burden. So in this study from Thurman, published in 2014, for example, in the top part of the panel, if you look simply at the number of deaths in thousands in various neurologic conditions, not surprisingly, Alzheimer's disease and stroke are by far the leading causes of death among neurologic conditions, and SUDEP is not a very common cause of absolute number of deaths. However, if you factor in years of potential life loss, meaning that young people have lost 30, 40, maybe 50 years of potential life, SUDEP then becomes the second leading cause of years of potential life loss following only stroke on this particular list of neurologic conditions. It's therefore an extremely common, I shouldn't say common, but an extremely important feature of public health that we recognize and try to treat and mitigate the effects of SUDEP. So understanding its risks is important. This comes from the guidelines published by the American Academy of Neurology by Hardin and colleagues in 2017, and really features a couple important categories. One is the severity of epilepsy, makes a lot of difference, and the other is the degree of supervision that the patient is under makes a lot of difference. So for example, in patients that have generalized tonic-clonic seizures versus those that don't, the risk of SUDEP is 10 times higher. The odds ratio is 10. In patients that have more generalized tonic-clonic seizures per year versus those that have fewer, and they broke it down between 1 or 2 per year versus more than 3 or more per year, the odds go up about 3-fold between patients that have only a couple tonic-clonic seizures versus those that have 3 or more. And think about it, 3 or more tonic-clonic seizures spaced over a year is not very many seizures. And there are probably many, many patients in all of our clinics who have at least 3 generalized tonic-clonic seizures per year. These patients represent the high-risk group for having SUDEP. Not being seizure-free poses about a 5-fold increased risk. Not adding an anti-seizure medicine when the patient is medically refractory poses about a 6-fold increased risk. And then conversely, if the patient has either somebody sleeping in the room with them, if they have a bed partner, the risk is reduced by 2.5 times that of baseline. And if the patients are monitored through some sort of listening device that may be as simple as a baby monitor, a radio device that allows a family member to listen for the occurrence of a seizure, the risk can be reduced by perhaps up to 10-fold. And we'll develop these thoughts a little further as we go along in the talk. So SUDEP is now thought to have 3 underlying basic mechanisms, several or all 3 of which can act in concert to put the patient at higher risk of having SUDEP. And we'll talk a little further about potential underlying cardiac mechanisms, potential underlying mechanisms of failure of arousal following a generalized tonic-clonic seizure, and then finally about the respiratory mechanisms that underlie the vast majority of SUDEP cases. Here's a figure from a paper published by Alex Petrucci in the lab of Gordon Buchanan here at the University of Iowa. Gordon has a lab that studies the relationship between sleep and seizures, which we'll talk about a little bit as we go along too. And I'll develop this model as we go through the talk, where basically the occurrence of a seizure, most notably a tonic-clonic seizure, can then propagate into the midbrain and cause arousal dysfunction. So the patient doesn't normally arouse and resume normal breathing mechanisms after having a seizure. The seizure can also propagate into medullary cardiovascular centers, causing cardiac arrhythmias and leading to asystole. And the seizure can also propagate into medullary serotonergic respiratory centers and cause apnea. And the apnea itself can cause cardiac arrhythmias and asystole, the final end result of which is SUDEP. And as this figure also highlights, there are some factors that tie into these basic mechanisms. So for example, the patient who has an epileptic encephalopathy, a cardiac channelopathy, we talked about poor seizure control already, the presence of generalized tonic-clonic seizures, maybe the occurrence of sleep apnea, although that relationship is not well known yet. And then there are also some external factors such as seizure occurring during night, maybe seizures occurring during REM sleep are more risky than those occurring during non-REM sleep. And then some other factors relating to the position of the patient, the observation that many patients who experience sudden death in epilepsy are found in their bed in a prone position, indicating that some degree of asphyxiation may have occurred after a seizure. And we talked about the importance of supervision or the risk factor of lack of supervision through the nighttime, all of which can then factor into these columns that then produce SUDEP as the end result. So we'll come back to this at the end after we've gone through the specific mechanisms here. So what is the evidence in favor of a cardiac etiology for SUDEP? Well, it's known that epilepsy patients have a higher incidence of structural cardiac disease like ischemic cardiac disease and cardiomyopathy than the general population. It's also known that long QT syndrome is more common in epilepsy than it is in the general population. And specific to SUDEP cases, it's been shown that long QT syndrome mutations have been found in 7% of people experiencing SUDEP, and an additional 15% of SUDEP cases have gene variants that may predispose to an arrhythmia. So it may be that some of these patients are put at higher risk because of some genetic predisposition to cardiac rhythm disturbances. It's also observed that oxygen desaturation, that is hypoxemia, increases the likelihood of QT prolongation. I didn't put it on this slide, but some of the epilepsy medications can also prolong the QT interval, and we need to watch out for that carefully. There are certain syndromes like Dravet syndrome that have increased risk of cardiac abnormalities, and these are thought to be related to the underlying channelopathy. So for example, Dravet, many cases caused by mutation of the sodium channel SCN1A. These patients have a combination of epileptic encephalopathy, generalized tonic-clonic seizures, and cardiac predisposition. Also in the potassium channel abnormality of KCNQ1, this would also produce a seizure condition and a setup for a cardiac arrhythmia condition. And then finally, it's well observed, if you work on an epilepsy monitoring unit and you record enough seizures, you will eventually see a seizure that causes a brief period of asystole. So that seizures can cause a failure of the cardiac systole, but very few of these cases on epilepsy monitoring units, if any, experience fatal asystole, and the asystole tends to be self-limited because the hypoxia that follows a seizure tends to help reverse the asystole. Shown here in a paper by Schule in 2008, a couple cases of patients who experienced brief ictal asystole, this one even less than 10 seconds with some bradycardia before and some bradycardia after. This one with an asystole of maybe 25 or so seconds, but then the cardiac systole is recovered spontaneously very quickly afterwards. This was a study that came out of 3 epilepsy centers, Northwestern, Cleveland Clinic, and Case Western. They found 10 patients who had ictal asystole, and that represented only 3 cases per 1,000, so it's not a common thing. 8 of these cases, though, had temporal lobe seizures, and by review of the video, they ascertained that these patients did not have apparent respiratory compromise. The caveat to this is that this was not done under conditions of formal respiratory monitoring. So these patients didn't have devices to measure nasal airflow or devices to measure chest and abdominal movement like we are now studying, and such as what would be done, for example, with a polysomnogram. And a couple cases were extratemporal, but these cases were extratemporal onset spread to bilateral tonic-clonic, and they did have apparent respiratory compromise. So you can't rule out a primary respiratory mechanism in some of these cases. How about factors in favor of an arousal mechanism? So in animal models, there are mice that are genetically made deficient in serotonin. So they lack normal brainstem serotonergic respiratory mechanisms, and these mice do not normally arouse under conditions of either hypercarbia or hypoxemia. So it appears that serotonin in the brainstem is an important tool, an important mechanism for arousing the animal or perhaps the human under conditions of hypercarbia, such as might follow a seizure. It's also observed in humans that some patients who have a generalized tonic-clonic seizure have a period of complete generalized EEG suppression known as postictal generalized EEG suppression, or PGES, that has been found in humans to correlate to a lower postictal SpO2 nadir, so they get more hypoxic than people who do not have this PGES. They also have a higher end-tidal CO2 compared to patients who do not have PGES, and PGES is more likely to occur following a seizure from sleep, which gets back to that thought about the relationship between tonic-clonic seizures happening in sleep that might place the patient at higher risk. And then finally, in favor of the respiratory mechanism, there is quite a bit of data to support this, including animal models. I've only listed a few, but there are more. So there are mutant mouse models that have seizures that result in sudden death, and the sudden death can be prevented to some degree if you mechanically ventilate the animals, so that respiratory resuscitation is successful at blocking the risk of sudden death. In people with focal and generalized seizures, it's now observed that they can have respiratory impairments that can include central apnea in up to 22% of people who've had generalized tonic-clonic seizures, and even a certain percentage of people with focal impaired awareness seizures have been shown to have some degree of central apnea. An interesting observation that came from our center, and this was discovered by our neurosurgery colleague, Brian DeLuey, is that amygdala stimulation, either left or right side, either spontaneous from a seizure or induced by electrical stimulation, can produce central apnea. And I'll show you some slides about this. It's a very interesting phenomenon that demonstrates that when a seizure enters into the amygdala, it can produce central apnea. We talked earlier about the risk of prone positioning, the factor of supervision or not, and the time of day related to sleep. And these may all have relationships to effective respiration or impaired respiration. And then finally, there was this landmark study called the MORTEMUS study, which stands for Mortality in Epilepsy Monitoring Units, that showed the relationship between seizure, respiratory compromise, and terminal asystole. And I'll show you that in just a minute. But first to this observation of Dr. DeLuey's regarding the amygdala. Here's a patient who was implanted for mapping of seizures prior to epilepsy surgery. The patient had a largely right-sided implantation with frontal and temporal grid electrodes and some subdural strip electrodes underneath the inferior frontal lobe and inferior temporal lobe. They also had electrodes placed into the amygdala in both the left and the right side. And here's a recording showing one of their habitual seizures with seizure onset about here from the right frontal subfrontal cortex. And it took about 50 seconds or so for the seizure to eventually propagate into the left amygdala and eventually into the right amygdala. But as soon as it entered the left amygdala, this patient who was breathing normally before became apneic. And the normal respiration is measured by nasal airflow, by oral and nasal thermistry, measuring the temperature of the breath in and out, as well as plethysmography measurements of chest wall excursion and abdominal excursion. And then the seizure ended and the patient wasn't completely breathing normally. They're having some artifact here and they're tracing, but very quickly resumed normal breathing afterwards. So a very elegant demonstration that seizure propagation into the amygdala produces central apnea. So Brian followed that up with some electrical stimulation through the amygdala contacts. And here on the top tracing is Brian providing electrical stimulation for 24 seconds to the left amygdala, and then 22 seconds to the right amygdala, showing normal respiration before, central apnea during the course of stimulation, and then resumption of normal breathing shortly thereafter with either left or right amygdala stimulation. And these patients desaturated down to about 90% SpO2. Would have certainly gone lower if the period of apnea had been longer. And this did not occur when stimulation was given to any other of the recording contacts in the patient's brain. It was specific to either the left or the right amygdala. And then here's the key figure from that MORTEMUS study in epilepsy monitoring units. This was a study that collected data from 160 epilepsy monitoring units around the world. And these centers reported 16 cases of SUDEP. Interestingly, 14 of which occurred overnight. So statistically much more likely to occur overnight than during daytime hours. And an additional 9 cases of near SUDEP where the patients were successfully resuscitated. And remember that these were studies that were done sort of before the period or in the time when we were just figuring out what sort of safety features epilepsy monitoring units needed to have, including continuous observation of the recording and respiratory and cardiac monitoring, and then resuscitation protocols. So unfortunately, in this series, 9 patients expired from their SUDEP on an epilepsy monitoring unit. And they're shown sequentially here as we go down the column. And for each patient, there's a bar that shows apnea in blue, followed by asystole in red. And in each one of these cases, there's a period of apnea that sometimes even lasts minutes before the asystole develops, leading to the asystole and the death of the patient. Minutes of respiration, in this case, short period of apnea, short period of apnea. But in all 9 of these cases, respiratory compromise preceded cardiac compromise. which indicates that the primary mechanism for SUDEP is probably a respiratory-driven phenomenon. So is there a way to measure this risk? This is what we ask at our center, and this is what we're actively studying right now. There's this study known as the Hypercapnic ventilatory response, dating back to the, I think, 1950s or 1960s. It's been observed in physiology laboratories that animals, including humans, respond to rising levels of CO2 by increasing their minute ventilation, by breathing more. Shown here in the lower right part of the panel, where there's normal respiratory rates and pattern when the patient is breathing room air, and then upon breathing 6% CO2, the area under the curve increases and the patient moves more air. And this is known as minute ventilation, or the amount of liters per minute that a patient breathes. Shown in the left panel is our respiratory therapist, Harold Winicke. And what he's doing is performing one of these HCVR tests, hypercapnic ventilatory response, or getting ready to, with a device that can be wheeled around into the patient's room, taken back to Harold's laboratory, taken to the clinic. It's quite portable. In the blow up here on the right side, you see the bags where the patient breathes the oxygen mixture and then the CO2 mixture. And what Harold can do is he can have the patient steadily increase their amount of CO2 respiration to increase their end-tidal CO2 expiration. And that produces a measurement of minute ventilation, liters per minute. They breathe a mixture of 50% O2, 6% CO2, and the balance with nitrogen. And this can be quite portable. And we think this serves as a possible biomarker of SUDEP risk, and I'll show you why. So my colleague Roop Sanju is very much involved in and leading this project. Roop has been looking at epilepsy subjects and HCVR for a few years now, and is actually heading into the stage now of trying therapeutic trials to try to reduce this risk and reverse this phenomenon of chemosensitivity and respiration in response to CO2. But what we find with our epilepsy patients is that there's, well, first of all, let me show you these top panels here. So this is graphed out on the x-axis as rising end-tidal CO2. So the more CO2 that the patient breathes in, the more they try to breathe out. So rising CO2 on the x-axis, rising minute ventilation on the y-axis. And shown here in panel A is the median patient, the one who falls right in the middle here. The slope of this response is about 2. So for every unit of CO2 increase, there's about a 2-fold increase in minute ventilation. So most people are around this, where they have a slope of about 2, increasing their respiration in situations of increased CO2. There are people that are very hyper responders. This is the highest person here on the right. They had a very high slope in response to rising CO2 levels. However, there are a few people who are on the left side of this, and they have very low slopes in response to CO2. Here's a patient with a slope of almost 0. So with rising CO2 levels, the patient did not increase their minute ventilation. In fact, this was a subject who 11 months later died of SUDEP plus the finding of cardiomyopathy. And that's this patient shown here with the arrow. This doesn't prove that a flat slope of HCVR is a risk factor for SUDEP, but it's very intriguing in proposing that possibility. And of course, we need more data in order to determine this conclusively. But the HCVR may be a very important test in assessing risk of SUDEP because it shows people who are vulnerable to conditions of rising CO2 level and don't appropriately respond in a normal ventilatory sort of way. So if we come back to our model, and I've simplified this a little bit and broken out some of the features, but if you think about a patient having a seizure under situations of risk, in bed, maybe not being supervised, the seizure can do a few things. And in fact, I drew the arrow wrong. There should be arrow going from seizure over to impaired arousal and seizure going over to prone position. So seizure produces impaired arousal, which produces an unawareness to resume normal breathing patterns. The seizure produces impaired respiration in a patient that might be susceptible to impaired chemosensitivity, rising CO2 levels, they don't breathe normally, leads to respiratory arrest. And the patient in prone position who cannot exchange O2 and CO2 properly and might lead to respiratory arrest. There may additionally be cardiac factors that increase the risk of cardiac arrest under these conditions, including intrinsic heart disease long QT syndrome, and channelopathy. But the end result of all of this is that the patient expires from SUDEP. So, key thing, what can we do about this? Well, we think we can intervene at the present time in some important ways. First of all, we want to try to optimize every patient's seizure outcome, seizure treatment. This means optimizing their medication, making sure they're adherent with their medication schedule, making sure they're avoiding risk factors like sleep deprivation, stress, alcohol, other things that might exacerbate a patient's seizures. We want to think about prescribing a rescue medication like midazolam or clonazepam for patients that have seizure clusters, because we don't want seizure clusters to lead to a larger seizure like a generalized tonic-clonic seizure. And then in appropriate patients who are medically refractory, we want to make sure we think about whether we can use epilepsy surgery or neurostimulation like the DBS or the VNS as a possible therapy for not only their epilepsy, but reducing their SUDEP risk. We also want to educate the patient and family about this. And I'll be frank, this is something that wasn't taught to me in residency, and it's something I've developed over time. But it's clear that patients and families really, really do want to know about this so they can do something about it. And what they can do about it is make sure that the patient with epilepsy adheres to their therapy, comes back to their follow-up appointments, does all the things that we think they should be doing, avoids seizure triggers, and again, treating seizure clusters. So that's an important step we can take right now to try to reduce the risk of SUDEP. In terms of sleep factors, there are pillows on the market that are built with a sort of lattice structure. That is, they have openings in them, and it makes it more easy for air to be exchanged in conditions of face down in the pillow. It might be that these lower the risk of SUDEP. We don't quite know that yet, but theoretically they should. And then the importance of nocturnal supervision and using alerting devices that I'll finish up showing you some data on. And then finally, Dr. Sanju, my colleague, is undergoing some pilot studies to see whether serotonergic medicines, SSRIs, that we use for treating things like depression, might also help improve the serotonergic tone of the brainstem and the respiratory centers that might then turn around this HCVR abnormality in patients that have very low slope. And we don't have data from that yet, but this work is in its very early stages. We may find that there's medication therapy that can reduce the risk of SUDEP eventually. So to finish with a couple thoughts about why both supervision and aggressive treatment of epilepsy is important. Here's a study published just the other year from Columbia University and Lisa Bateman's group showing that patients who underwent epilepsy surgery, shown in the dark gray bar, versus patients who were medically managed but had refractory epilepsy in the light gray bars, experienced a marked reduction in SUDEP rate. And this is, again, cases per 1,000 per year. In the patients who had surgery versus those who did not have surgery, the SUDEP risk was significantly reduced, not only at 2 years, but it sustained at 5 years and 10 years, and probably to some degree, even 20 years after having had epilepsy surgery. So treatment of epilepsy really, really matters in these cases. And then finally, the matter of generalized tonic-clonic seizures combined with the matter of overnight supervision is shown in this study from the Karolinska University Hospital in Sweden, which shows as reference the patient who shares a bedroom with somebody but does not have generalized tonic-clonic seizures, and they're assigned a rate of 1. And then in comparison to that, the patient that has supervision but has generalized tonic-clonic seizures faces an almost 20 times higher risk of SUDEP compared to the patient who doesn't have generalized tonic-clonic seizures. But not sharing a bedroom with somebody is an even greater risk factor. And the patient who has generalized tonic-clonic seizures and does not share a bedroom faces an almost 70-fold increased risk of SUDEP compared to the patient who does not have generalized tonic-clonic seizures and yet shares a bedroom. So supervision matters, and controlling generalized tonic-clonic seizures matters a lot. Hopefully that's been a good, if brief, overview of where we stand with SUDEP right now. I encourage you to think about it in your patients. I encourage you to treat your patients' epilepsy as aggressively as possible and talk to them about these factors they can use at home that might help reduce the risk. I'd also like to close by thanking my colleagues at the University of Iowa. These are the members of the SUDEP research program at Iowa, including my chair, George Richardson. My neurosurgery colleagues, Matt Howard and Brian DeLuey. Mentioned Rup Sanju in his work. He's a neurologist in our group. Brian Gelbach is our internist pulmonologist who teaches us everything about respiration. And I mentioned Gordon Buchanan's work too. And then we're supported by the tremendous efforts of Deidre Dragon, who's our study coordinator, Harold Winnicky, our respiratory therapist, and our EEG technologists, Deanne Tadlock and Prairie Sievert. And I'd like to close by, again, thanking the organizers of the Congress and the moderators of this session. Very, very grateful for the invitation and very proud and happy to have participated in your Congress. And I wish you all well. Thank you.